The link is active on the website, isn't it? Hello? Hello?
Hello,
Sir.
it's live, so you can start now.
Okay, fine. Okay. Lavanya, please go ahead.
Okay. Good morning, everyone. Myself, Dr. Lavanya. So today we will be discussing regarding MDR gram-positive organisms and their treatment options. Why is it very important to know about MDR gram-positive? In the last decade, we have always worried about gram-negative sepsis and bacteremia. Because it was more like 75% of gram-negative organism infections and the rest was gram-positive. But in the last decade, the percentage has been increasing there is increasing resistance in the gram-positive infections. So it is becoming a major public health concern. And because of this MDR, the increasing resistance, there is increased antibiotic usage and increased healthcare costs and increased length of hospital stay and morbidity mortality has increased. So it is very important to know along with the MDR gram-negative bugs, it's always important to know the gram-positive bugs also. So what are the most common sites of gram-positive infections? Most commonly what we encounter in IACU. We all agree that the most common site of infection is skin and soft tissue infection. It can be as superficial as a cellulitis, deeper like necrotizing fasciitis, and maybe a deep-seated abscess, and till the level of bone causing osteomyelitis also. This is the most common site of infection, gram-positive infection. And the other sites being meningitis, which is more commonly caused by streptococcus or MRSA. And then pneumonia, hospital acquired or community acquired, both pneumonias can be caused by gram-positive organisms. And other sites like CRBSA, that is catheter-related bloodstream infections, or CLABSI central and associated bloodstream infections. And also bacterial endocarditis, infective endocarditis, along with GI infections, which are mainly caused by enterococci, hepatobiliary pancreatic system, and also bowel infections can be caused by gram-positive organisms. And other sites being UTI, urinary tract infections. So these are some of the commonest sites of the gram-positive infections. Now, what are the common gram-positive bacteria we encounter in our practice? Most commonly, Staphylococcus, Streptococcus, and Enterococci species. The lesser common organisms are Bacillus anthracis, Clostridium perfringens, Clostridium difficile, Listeria monocytogenes. Most commonly, all these organisms are seen in immunocompromised and elderly patients, and nocardia and actinomyces and etc. So the most common gram-positive bacteria we'll be discussing in detail. This is Staphylococcus, which looks like this, which is a spherical shaped bacterium, gram-positive, which appears in a grape-like clusters. The second one is Streptococcus, which looks like this, which appears in chains and spherical shaped bacterium. And the third one is Enterococcus, which is oval shaped bacterium and usually appears in pairs. So the common gram-positive infections, there was a study which looked at the prevalence of gram-positive infections. This is an international study, global study, which was done in 2017 and published in 2020. So which has tried to see all kinds of infections, drug resistant, multi-drug resistant, and the other gram-negative, gram-positive, all kinds of infection. In that, the prevalence of gram-positive infections, they have stated as 37%. Usually, the burden is around 23 to 47%, even in Indian scenario. So this study has said 37% is the prevalence of gram-positive infection. That is globally. Now, Indian estimate, if you compare from 2009 to 2014, the MRSA incidence or prevalence has increased from 29 to 47%. And VRE from 2007 to 2020, the VRE, vancomycin-resistant enterococci, the incidence has increased from 1% to 9%, which is very alarming because when the resistance has been over the last decade has been increasing in gram-positive infections also. And let us discuss in detail regarding most common gram-positive bacteria. The first one, Staphylococcus aureus. So, which is a gram-positive organism which appears in grape-like clusters. It can grow in any wide range of temperatures like 18 to 40, and that's why it is most common gram-positive infection. And also it can grow in aerobic and anaerobic conditions also. Now, what is the most common mechanism of resistance with Staphylococcus aureus? So the most common is the SCC-MEC gene, most commonly called is MECA gene. SCC means staphylococcal acid chromosome, MECA gene. This gene is responsible for the resistance. How it encodes a penicillin binding protein, which is altered. There is a modification of penicillin binding protein leading to formation of PVP2A, which has a less affinity to beta-lactam antibiotics. This is the main mechanism of resistance in Staphylococcus aureus and how MRSA originated. Now, how vancomycin resistance occurs? This is due to the same way MECA gene. Here it is multiple genes from VAN A to Z almost they are there, but most common is VAN A gene, which is responsible for vancomycin resistance. If you see the vancomycin resistance is definitely clearly more in Staphylococcus aureus, but also in Enterococci species, both Faecium and Fecalis. Enterococcus faecium exhibits more vancomycin resistance than Fecalis. So that is more difficult to treat. Now, there is some terminology with respect to vancomycin resistance. That is vancomycin intermediate Staphylococcus aureus. Here, the MIC for vancomycin would be around 4 to 8 mg per liter. There is a reduced susceptibility to vancomycin, but can we still use vancomycin? Yet, maybe yes, good doses we can start, and then we have to look for any treatment failures. Close monitoring is required, but usually it is not suggested to start with the vancomycin. H-visa is heterogeneous. As the name suggests, it is heterogeneous. Usually in our standard MIC testing, it will show as MIC is less than 2. That means it is susceptible. But there are some cells with the subpopulation of cells which have intermediate resistance. So both are there. So it is difficult to pick up in the standard testing. Hence it is always, it can get missed out and it is very difficult to diagnose and treat. VRSA is vancomycin resistant Staph aureus, which is fully resistant to vancomycin. The MIC of more than or equal to 16 mg per liter. This is VAN A gene is responsible for this. So if you look at these three, the resistance is maximum with VRSA, followed by Visa and then H Visa. But it is clear that it is more, there is more complexity in treating H Visa than other two, because the detecting it is difficult. Because the name itself suggests that heterogeneity is there, that becomes difficult to pick up. The mechanisms of resistance, the common mechanisms of resistance in MRSA, rather any other organisms, the most common resistance patterns being the decreased membrane permeability to the antibiotic, the modification of the target site, point mutations, inactivation of antibiotics by enzymatic degradation, or efflux pumps which push out the antibiotics. These are some of the most common mechanisms of resistance where our antibiotic should be, the future antibiotic should be active. Now, what are the common infections that we come across with Staph aureus? Again, as we discussed, it is mainly skin and soft tissue infections, from superficial cellulitis to the deep-seated abscess. and it can cause something called scarlet skin syndrome, which can be deadly sometimes. And usually it is a toxin mediated, produces toxins. The virulence factors are toxins, enzymes, and immune modulators. The toxin mediated, there can be food poisoning and toxic shock syndrome, which is again a very dangerous condition. And others, like it can cause, apart from skin and soft tissue infections, it can cause pneumonia, hospital-acquired and ventilator-associated pneumonia, and surgical site infections also. Now, how to treat Staph aureus? So if it is methicillin sensitive, that is simple penicillin sensitive. It is straightforward. We can give a penicillin that can be either amoxicillin or a cloxicyllin. Amoxicillin with the doses of 500 to 1 gram every 4 to 6 hours, 4 to 6 divided doses. And cloxicyllin and the dose being 500 mg IV every 4 to 6 hours. So these are some simplest thing to treat. And also we can use all first generation cephalosporins also if there is a methicillin sensitivity. Like cephalexin, cefazolin, cephalothin we can use. If patient is allergic to these penicillins or beta-lactam antibiotics, then our option is our favorite drug, vancomycin. So this is methicillin sensitive and easier to treat. The next one is the most favorite MRSA, which the drug of choice currently will still remain as vancomycin. Vancomycin is a glycopeptide antibiotics. We all know it inhibits the cell wall synthesis. And it is given in the doses of 15 milligram per kg per dose every 12 hours. This is the initial dosing, but subsequent dosing has to depend on therapeutic drug monitoring. The steady state trough concentrations are important. If you can look at that, that is the most ideal situation. To maintain around 15 to 20 micrograms per ml of the trough concentration will avoid the side effects, and also the adequate dosing will be delivered, and the persistence pattern will also decrease. So the problem with vancomycin is the renal effects, that is acute kidney injury. So are there any other options for MRSA apart from vancomycin? Even if vancomycin is sensitive, there are few options. First one is daptomycin. Daptomycin is a lipopeptide. Lipopeptide which disrupts the cell membrane, disrupts the cell membrane integrity. That is the mechanism of action. And it is given in the doses of 8 to 12 milligram per kg once daily dosing. And if at all there is a renal dose adjustment has to be done for this, maybe as the GFR decreases, it may have to be given on alternate days. It is available as both 350 mg per vial and 500 mg per vial. And the problem, there are two problems with this. One, it can cause severe myopathies, muscle pain and myopathies. And second one is it is inactivated by the surfactant. So we cannot use it in pneumonias. So is there any other option for MRSA? Yes, teicoplanin. Why we usually don't mention in all recommendations is only in Indian setup we in guidelines which included teicoplanin, but because it is not available in the US yet, FDA approval of late it was not given. Recently it was given as I came across. But it is still not available in the US. That's why most of the recommendations would not mention teicoplanin for MRSA. Teicoplanin is like vancomycin, again, glycopeptide. Same, it inhibits the cell wall synthesis. And it is given in the doses of soft tissue infections, given in the doses of 6 mg per kg per dose. For 12 hours for first 3 doses, and then followed by once daily dosing. In cases of bone joint infections or serious infections like endocarditis, we may have to increase the dose to 12 milligram per kg per dose, and continuing for 3 doses every 12 hours. So are there any other options for MRSA apart from these three? Second line drugs will be linezolid. Linezolid is an oxazolidinone compound, and which inhibits the protein synthesis. Usually given in the dose of 600 mg twice daily. And so this can be used in some certain set of infections, which I'll be discussing. And other drugs, which are newer agents like ceftaroline and ceftobiprole, which are fifth generation cephalosporins, which I will discuss in subsequent slides, and even telavancin. So in 2016 infectious diseases guidelines, it was given some few set of guidelines. So to make a clear decision, the vancomycin and teicoplanin are the first choice of drugs for MRSA. There's no doubt about that. When in doubt, we can always use a teicoplanin also, if there is apart from vancomycin. Then linezolid in cases of soft tissue, surgical site infections, and daptomycin. This is most important point, where in bacteremia, if you isolated blood culture, if you isolated MRSA, then daptomycin would be the drug of choice, and also in complicated surgical site infections, skin and soft tissue infections. I'm very sorry. It is the drug of choice. So this was the methicillin sensitive and resistance MRSA, and how to encounter vancomycin resistance, the patterns which we already discussed, VRSA or VISA. So if this resistance is there, vancomycin resistance, we may, it is daptomycin, but we may have to consider other drugs also. The dual therapy is more efficacious than a single drug. So it is better to use a high dose daptomycin, that is 8 to 12 up to 12 milligrams per kg per day. And along with the agents like gentamicin, rifampicin, linezolid, trimethoprim and sulfamethoxazole and beta-lactams. The idea is to give a dual therapy to act better, and it is more efficacious compared to a single drug. If there is a decreased susceptibility to daptomycin, the other option for MRSA is streptograms, quinaprestin and dalfoprestin. So along with this, we can add a linezolid and trimethoprim sulfamethoxazole and telavancin. There are some combinations that have been given in guidelines. But like as we understand, VRSA and VISA, the drug of choice, like again, it is not mentioned, teicoplanin is not mentioned here because US does not have it. So there is high dose daptomycin mentioned with other drugs. So when it comes to ICU settings, mainly complicated SSTA, surgical skin and soft tissue infections, the options are, we all agree that vancomycin is our go-to drug immediately. Other options being daptomycin, telavancin, clindamycin, and linezolid. These are the options. If there is a bacteremia and infective endocarditis, for bacteremia, again, daptomycin, initially vancomycin is the choice. And if there is a bacteremia, we have to use a daptomycin. If it is a prosthetic valve, vancomycin has to be given along with gentamicin and rifampicin. And in cases of bone infections, again, the same set of antibiotics along with rifampicin as a alternative agents. In CNS infections, because of the CNS penetration, the options are vancomycin, linezolid, and we can use a trimethoprim sulfate. So this is about MRSA. Let us talk about Enterococci. Enterococci can usually, when we usually see gram-negative sepsis, Enterococci can also cause up to the extent of bacteremia, sepsis, and septic shock. Most common sites of Enterococci infection is surgical site infection, UTI, urinary tract infection, bladder and the urinary tract infections, and central line associated bloodstream infections, and also catheter related bloodstream infections. So these are the common sites for Enterococci infection, and also GI infections can cause. The virulence factors, as opposed with Staph aureus, it had toxins and enzymes, and here it is cytolysine additions, hemolysins, etc. The two species in Enterococci are fecalis and faecium. Faecium is more notorious and more resistant to vancomycin. In fecalis, it can sometimes Enterococci fecalis is a simple, may not be that multi-drug resistant like Fecium. So when it is susceptible to ampicillin and aminoglycosides, if there is no high level resistance for aminoglycoside, we can give this combination ampicillin plus aminoglycoside. If there is a high level resistance to aminoglycoside, that has to be skipped, and the ampicillin has to be added with any other drug. Ceftriaxone, fluoroquinolones, daptomycin can be added. So the same, if it is a susceptible enterococci, then the preferred agents will be ampicillin 1 to 2 gram every 4 to 6 hours. Alternative agents will be vancomycin and daptomycin. But one would agree, if the patient is very sick in ICU settings, our main concern is like if there is a sepsis, we all would usually go with the higher antibiotics, that not higher, that is alternative agents like vancomycin. We are almost worried, we are always worried whether ampicillin will really give better results in that settings when patient is already sick. Now, if there is a vancomycin-resistant enterococci, it can be fecalis or Fecium, but here it would more talk about Fecium because the resistance is more in Fecium species. So if still ampicillin MIC is less than 64 and there is no high level resistance to aminoglycoside, we can give a high dose ampicillin up to 30 gram per day and add aminoglycoside to it like gentamicin, streptomycin. But if aminoglycoside is exhibiting resistance, then we have to go for other agents. Now, if ampicillin MIC is more than 64 and there is no resistance to aminoglycoside, here daptomycin, because MIC of ampicillin is more, we cannot use that. So daptomycin along with aminoglycoside, we have to add another active agent like tigecycline, rifampicin, fluoroquinolone. If there is resistance to aminoglycoside, the option would be even we can use a daptomycin or streptogrammin, linezolid along with another active agent which is mentioned here. So it looks like maths, but simple to understand is if there is a sensitive vancomycin resistant enterococci, if ampicillin is sensitive, as in like MIC is less than 64, use ampicillin. If it is more than 64, use daptomycin along with any other active agent. So what are the conventional drugs that have been available for gram-positive infections, which we have discussed in last slide, most of them? Vancomycin, linezolid, daptomycin, teicoplanin, clindamycin. Clindamycin is a lincosamide antibiotic and which typically used in doses of 600 milligrams IV every 6 hourly. And tigecycline is a glycyl cycline derivative, more like a tetracycline group of structurally similar to tetracycline, which was introduced mainly for the intra-abdominal infections. So these are all and which is active against MRSA. These are all the conventional drugs which we have been using and we are still using. And what are the newer agents that are available for the gram-positive infections? Ceftaroline, ceftobiprole, which is the 5th generation cephalosporin, tedizolid, delafloxacin or levonadifloxacin, fluoroquinolones, tilavancin, dalbavancin, oritavancin, and orivacycline and omadacycline. These we will discuss in nutshell. So cephalosporins, that the newer cephalosporins that are available are ceftaroline and ceftobiprole. We know that they are cell wall synthesis inhibitors. Ceftaroline was approved by FDA in 2010 for complicated skin and soft tissue infections and community-acquired pneumonia. And it is effective against MRSA and Visa both, given in the doses of 600 milligrams twice daily. And ceftobiprole is also approved in 2007 for pneumonia. And it is effective against MRSA, penicillin-resistant Streptococcus pneumonia, and Enterococcus fecalis. And it is given in the doses of 500 mg IV TID. Multiple studies have showed the potency and higher efficacy of these drugs for use of MRSA and Visa. And the next drug is the oxazolidine known compound. like linezolid, the same comparable spectrum of activity. Spectrum is same, but it has a higher potency and bioavailability. Hence, it is available of oral form also. And 200, and we know that it inhibits the same like linezolid, inhibits the protein synthesis by binding to 50S subunit. And it is given in the doses of 200 milligrams IV for 6 days, once daily. And skin, it's commonly used for, can be used for skin infections, pneumonia, and VRE organisms. Compared to linezolid and teicoplanin, there is a less incidence of thrombocytopenia, which is around 0.9% that was mentioned in a study. And next one is quinolone, nucleic acid synthesis inhibitors. And quinolones, they bind to DNA gyrase and topoisomerase 4 and inhibits the DNA synthesis. And the newer quinolones, delofloxacin, which was used, which is introduced and used in acute bacterial skin and skin structure infections, which is caused by MRSA. There are oral form, that is oral and IV both are available. And this MICs compared to any other quinolones are 3 to 5 fold lower than other quinolone MICs. So another drug which is being increasingly used, that is levonadifloxacin, which comes under the commercial brand name Emroc, also available oral form Emroco, which is a quinolone, basically benzoquinolisine fluoroquinolone. Basically, it has a tricyclic structure, which gives its the most potent anti-staphylococcal activity, and even like in pus acidic environment also it acts better because of the structure, the hydroxyl group, OH group that is there. And it is effective against MRSA, quinolone resistant, other quinolone resistant, Staph aureus, and VRSA also. So what is the most important thing about it? It has the highest lung penetration when you compare with any other quinolones. So it has a proven activity against respiratory pathogens, macrolide and penicillin resistant Streptococcus pneumonia, Streptococcus pyogenes, Haemophilus influenzae, Moraxella catarrhae. So you name it, it has a wide spectrum of activity, and its potency is also very high compared to other quinolones. And both oral and IV forms are available. Oral 1000 milligrams twice daily, and IV 800 milligrams twice daily. It does not need a renal or hepatic dose adjustment. That is one more advantage. And if you look at the spectrum of levonadifloxacin, its prodrug is oral form, that is alan levonadifloxacin, which is also active. So if you look at the spectrum, everything it covers as per the leaflet, it covers everything. Staph, Enterobacteriaceae, non-fermenters, antibiotic, Pseudomonas, Esnetobacter, other atypical organisms, anaerobic coverage, Enterococci. So most of it is covered by levonadifloxacin. Now, tetracycline analog omedacycline, which was approved by FDA in 2018, it is active again, wide range of wide spectrum of bacteria, both gram-negative, gram-positive, anaerobic coverage is also there. And it was used in community-acquired pneumonia and acute bacterial skin and skin structure infections. And in the doses of 100 milligram twice daily for 2 doses, then once daily dosing. And the same derivative, the tetracycline analog, that is eravacycline, which has higher potency than TG-cycline. Again, as TG-cycline, it was introduced more for complicated intra-abdominal infections, and also effective against MRSA, Enterococcus fecalis, gram-negative anaerobes in aerobes and anaerobes. The dose being 1 milligram per kg IV for 4 to 14 days. Lipoglycopeptides, again, it inhibits the cell wall synthesis and disrupt the cell membrane also. The options of lipoglycopeptides in last decade that were approved were tilavancin, oritavancin, and dalbavancin. So tilavancin, which is like has a wide spectrum of coverage and covers all MRSA, VRE. 10 milligrams of per kg IV once daily dosing is there. Here the importance is the simple administration. Vancomycin as a single dose in 1200 milligrams, 1.2 grams. There is no renal dose adjustment required. Dalbavancin has very long half-life and can give as a once a week dosing. So that is the unique point about it. So these are the lipoglycopeptides. So having said that, so many newer agents and the older agents also, we are trying to hit the same points again and again in a different formulation. So there is all the possibility that in future these antibiotics will again develop resistance. So there will be resistance against these antibiotics. So are there any approaches that we have to look at in future to overcome resistance? There are a few compounds which are still under research. Extensive research is going on. We may get results in coming decades. So one is tixobactin, which is produced by an organ, the bacteria itself, that is Eleftheria terrae, which is a species of beta proteoid bacteria. Again, it inhibits the cell wall peptidoglycan. It binds to precursors like lipid 2 and lipid 3 and is very effective against, in the studies, it is being effective against MRSA, VRE, and all other gram-positive organisms, and also some gram-negative coverage has been there. Bacteriophage, even before the antibiotic era, it was discovered, but because we had options at that time, we were looking into the antibiotics. But right now, because antibiotics, there is increasing resistance, again to look back at bacteriophage therapy, which by giving bacteriophage therapy, it enters the bacterial cells. And by any of the process, anything, protein synthesis, nucleic acid synthesis, cell wall, cell membrane disruption, and cell wall synthesis inhibition, all kinds of processes, bacteriophage can kill the bacteria. And it also has a role in eradication of bacterial biofilms. So in future in future there are some studies are actually ongoing in for Pseudomonas infection with the bacteriophage. And other experimental or under research treatments, which just wanted to make a note. Malacidins, which are soil microbiomes, which are being used in research, and antimicrobial peptides, which are extracted from the venom of insects. And this is also is under research. Cannabinoids, odilorhabdins, and nanoparticles. We all know nanotechnology now is increasingly is under research to deliver the antibiotics and the targeted approach. So in future, it may give us some light. It may give us some extra options for a better treatment. So the another important gram-positive infection I wanted to make a note here, which is a Clostridium difficile infection, which can cause a pseudomembranous colitis and antibiotic-induced diarrhea, antibiotic-associated diarrhea. Almost in 25%, the incidence being 25% in the immunocompromised individuals. The risk factors for Clostridium difficile are previous antibiotic exposure, elderly patients more than 65, previous hospitalization and are in long-term care facility, and the continuous usage of acid suppression therapy, immunosuppression, and diabetes, any abdominal surgery, end-stage renal disease, and IBDs. So these are some risk factors for Clostridium difficile infection. The main point here is antibiotic exposure, recurrent antibiotic exposure, and in a debilitated condition and elderly, they can develop this infection. When the patient has diarrhea and the risk factors for C. difficile infection, if there are more than 3 or more diarrheal stools in last 24 hours, and there was no other factor like laxative or any other explanation for diarrhea, it is suggested that enzyme immunoassay is to be done on stool for GDH antigen and C. difficile toxin A and B. If both are positive, clearly it is positive, we have to start treating for C. difficile. If antigen is positive, GDH, toxin is negative, then it comes in indeterminate area where it can be a colonization or infection. In that, we have to do a PCR technique and culture and prove it. And if both are negative, it is definitely negative for C. difficile. How to treat the IDSA guidelines for Clostridium difficile infection. If there is an initial episode, the preferred regimen would be fidaxomicin 200 mg twice daily for 10 days. This is the standard dosing. And also alternative regimen, if it is not available, fidaxomicin, we can use a vancomycin, that is 125 milligram 6th hourly for 10 days. So also, if at all other drugs are just in case not available, we can use metronidazole for a non-severe infection, orally 500 mg thrice daily for 10 to 14 days. So fidaxomicin has a minimal systemic absorption, but we have to be careful if there is any macrolide, is basically macrolide. If there is any macrolide allergy, we have to be careful. And oral vancomycin also has minimal systemic absorption. And always anywhere when the long-term vancomycin is being used, it is better to monitor the drug concentrations. And metronidazole, if you use for longer time, can cause a neurotoxicity that we have to keep in mind. If there is a recurrence of C. difficile infection, either you can use a standard dosing or better is to use a extended pulse dosing. That is use 200 mg twice daily for 5 days, then once every other day for 20 days. This is an extended pulse dosing of fidaxomicin. The same way, vancomycin, we can use a tapered and pulsed regimen if there is a recurrence. And there are adjuncts like besletoxumab with a dose of 10 milligram per kg IV can be given during the once during the therapy. And if there are recurrence, there is apart from first recurrence, if there are subsequent recurrences, we can use either of these fidaxomicin extended pulsed regimen or the tapered and pulsed regimen. And you can consider fecal microbiota transplantation in cases of if a patient has received appropriate antibiotic for more than 2 episodes of recurrence, then we can consider that along with besletoxumab. And also rifaximin can be used. And if it is a fulminant C. difficile infection, then vancomycin 500 milligrams via oral or nasogastric tube, or and along with metronidazole with IV 500 milligrams 8th hourly. If patient just in case has ileus, so oral form will not work, maybe rectal retention enema can be tried. So, and yes. So fecal microbiota transplantation, as the name suggests, basically the human fecal material which we are introducing into the gut to change the entire gut flora, which may prevent increasing the MDR pathogens to translocate and cause the sepsis. So this is maybe really not acceptable in the cultural and religious settings of India, but not it is being used, but not in India. Not maybe the alternative, the end option to for some of the severe gram-positive infections. Thank you, sir. Thank you all.
Thank you. Srinivas is there.
Yes, sir.
Srinivas, go ahead.
Yeah, you go ahead then, sir.
Okay. Thank you, Lavanya. I agree with you on the idea that the incidence of gram-positive, resistant gram-positive infections are on the rise. But I still feel it is the predominantly gram-negative organisms which are a major problem today. Nevertheless, the problem comes when we are trying to use empirical gram-positive coverage. Now, that's when we have to be a little careful. Because until unless you have a very high incidence of MRSA within your ICU or a high incidence of Enterococci, subjecting patients to empirically, adding anti-MRSA or a Enterococci cover may not be justified until unless there is a proper clinical setting where you suspect a high incidence of these organisms. Routine empirical usage of anti-MRSA, I think, should be avoided. So that's the reason why, please, again, what we often repeat, what we often tell is get in touch with your microbiologist. Look what is the incidence of MRSA in your ICUs, in your place, before you start using empirical coverage. Thank you.
Yeah, thank you, Ghanshyam. I think what you said is absolutely true. We cannot extrapolate Western guidelines into our practice because our resistance patterns, our problems are little different. But as a culture, if the unit uses a lot of macrolides, if the unit uses a lot of levofloxacin, quinolones for as an empirical therapy, historically the incidence of MRSA has been very high. But unless specific situations, empirical MRSA cover is still not needed in the Indian context. And again, as with all other antibiotics, meticulous looking at the source and discipline is probably the only way. Thank you, Lavanya, for a very comprehensive review of the gram-positive resistance options available for us. So please do join us again next week for another program on the Higgs platform. If you have any queries or comments on today's topic, please post them on the group from where you got the link from, and we will answer them at the earliest possible opportunity. Please do register for Higgs meeting in June. Very few slots are now open. We have had an overwhelming response to our early bird registration. So the seating capacity in the auditorium is a hospital auditorium, so the seating capacity is limited, unlike a hotel. So please do register early, and we'll all see you in June. We'll see you again next week with another session on the Higgs platform. Thank you very much.
And
have a good day.
Steven, just today is the last day for the early bird. If anybody is still interested, please utilize this offer because today is the last day for the early bird for the Higgs.
Thank you, Ghanshyam. Thank you.
Thank you.
Thank you.
Thank you, Lavanya.